So thank you everyone for joining the Central Oregon Health Council Board meeting for today, April 8th. And for introductions, what I would ask everyone is to put your name in the chat box so that the Health Council staff can know that you are here. And are there any, I see a couple of names I'm not used to. So Zachary and Cindy, are these people I should know?
Hi, Rick. It's Cindy Sagner with Summit Health, and I am Justin's backup for our.
Okay, good. We've been all talking about how Justin needed some backup. Thank God you're here to take care of him. And Zachary? Is there Zachary Correa? Okay, so Kelsey, if you could keep reaching out, whomever that is, might just be away from their computer at the moment. And Mitchell Carr?
Yeah, I'm a contract specialist with the local OFNHP 5017. I think I'm just listening in on this this meeting to see what you guys do.
Okay, sure, great. Welcome, and we'll go from there. Amy and Teresa, we all know you, I'm assuming. That's my working assumption. So we will get started. Oh, any public comment? Okay. So action items and approve the consent agenda. Can people take a look at the consent agenda, which is the board minutes and financials and the written reports? Is there any discussion? Can I have a motion to approve the consent agenda?
I move adoption of the consent agenda. It's Linda Johnson.
Is there a second?
Gary Allen, I'll second.
Thank you, Gary. All in favor, say aye.
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 Motion or
Aye. Aye.
Opposed? Okay, great. Patient story. Eric, are you with us? Are you able to deliver that patient story?
Eric is not with us. He says that he's having signal trouble with his phone. He apologizes. He's not able to make it work right now.
Okay. So then we'll just move on. And if he's able to connect later, we can go there. So Linda, you are up. And this is about board policy book.
Yes, I hope everyone has had a chance to look at the board policy book in close detail in your packets, or you could look at the amendments we made since the last month's version. As you may recall, last month's was an opportunity to review and provide input. A number of people provided input after one of the council members discussed some discomfort about the close linkage or perceived close linkage to the Carver model of policy governance. And at the board meeting and at the governance committee meeting, we discussed that. We looked at 3 or 4 different types of edits that we could make. And what you see before you is are the changes that we made. Just to give a bit of background, and I'm going to ask that any of the governance committee members please jump on board so that if I haven't captured the essence of the discussion clearly, you can improve it. What we talked about with the number of changes there, we know there is some discomfort about whether we are following a strictly Carver model or something else. And in our discussion, we talked about policy governance is a continuum. And we are somewhere between a strict Carver model and a scintilla of suggestion of a Carver model at the other extreme, and that we are somewhere in between. And we've talked about this in several meetings, and we found that the more descriptive we tried to be about what we weren't, created a little more confusion about what we are. And so we felt that the edits that were made to replace the in front of the policy governance model to a more general policy governance model, which would imply the continuum, is probably the best we can do at this time, coupled with a discussion here today and an opportunity to continue to improve it. There was also a suggestion that we change a sentence in section 2.1.4, I believe. And as we dove into that and looked at the possibility of creating a glossary of key terms, and we really looked at the one sentence, we realized that the sentence didn't add any value and it created confusion. And removal of the sentence didn't cloud the issue or add or amplify or provide clarity on any other issues. So the edit you'll see there in that section is simply to remove the sentence. So at this point, I think we're open for board questions, discussions, and this is a committee presentation. And committee has endorsed this document for your approval. Committee members, anything to add?
I think you covered it well. Nothing to add.
Nothing.
Questions from board members?
Just letting you know that Dan's having some difficulty dialing in, and I just gave him some additional information. Hopefully that'll help him connect. I see Leslie's hand up, Linda.
Okay.
Yeah, Leslie?
I think that's the first time I've ever used that. It was very empowering. I just had one small piece, I think, just an observation. I know that you all have a separate 501c3 policy for conflict of interest, but was just curious if the language in this manual you just, or that you've drafted is a duplicate or if it conflicts perhaps.
Can you repeat your question? I'm not sure I understood. Are you asking, do we include a section on conflict of interest?
I know that you do have a section on conflict of interest that was in the packet. I just wasn't sure if the manual, if what you've just presented is a duplicate of the separate 501c3 policy that you have for conflict of interest, or if it's the same and a duplicate.
I think it's intended to be a duplicate, but I personally haven't cross-checked the wording. Its intention is to be consistent.
I would assume. Okay, just wanted to make sure. Thank you.
Good question.
I will confirm.
Okay, other questions? Ms. Mills, my preference would be, this may be, as you call it, Bobby's rules of orders, but I would feel more comfortable completing this discussion and completing a vote after Dan has joined us than to do it in his absence, given his particular role on the committee. So, Tammy, you have your hand raised.
I'm following Leslie's lead. Thank you, esteemed chair. Just would love to offer that both Dan and Eric had deep interest in this particular topic. And so I would maybe see if Kelsey could glean any insights or comments that Eric might have as well, if he's maybe able to have access to email. I too share that concern of moving forward without those two voices present. So that's all. Thank you.
Yeah, thank you for that. And I would tell you that Eric sits on the governance committee, so we know he had his 100% support, but I do concur with you, Rick, that we should wait till Dan can weigh in as well. So we could continue in our agenda and come back to this. I think Dan's trying to connect.
And I
Okay.
fully support that as well.
Okay, so we'll just delay and circle back at a reasonable time to make that, to complete the discussion and head toward a vote, assuming that we're ready for that. Okay, then do we have the ops chairs here? I'm not seeing any names that jump out to me.
Yeah, Emily Teresa's here, but Emily was going to join us as well. Michaela, do you know what time she planned to connect?
At 1 o'clock.
At 1, okay.
We can go to Brad.
Brad's here.
Whoops. Okay, so we're jumping the agenda down to Brad and putting him on the spot and for CAC quarterly report out. So the agenda today does have some key report outs from committees that report to the board. So that's what this theme is about. So, Mr. Porterfield.
Yeah, and I think it's worded correctly. I'm not planning to report out as much as I'm planning to ask for board input.
Oh.
And get kind of see what you all think of the CAC. So I'd like to do that. We got about 15 minutes, I think. And I could, I guess, premise it by sharing that I'm the new CAC chair as of, I don't know how many months ago, maybe 6 months ago. And so I've been, asking questions and just trying to figure out what is the purpose of the advisory council? And what exactly are we doing that is truly advisory to the board? What is our role? And I have to say that I don't see us doing a lot of advisory to the board. So hence the question, and that's why I'm bringing the question to you. Now that I'm on the board, it's an uphill climb to figure out, what exactly the board does and what my role is on the board. But as chair of the CAC, I'd like to get your input. Most of you have been on this board for quite a while. And you've had some interaction with the Community Advisory Council. Oops, sorry about that. Maybe some of you have even been on the Community Advisory Council, I'm not sure. But if you don't mind, so I'll go through and ask some questions. And we don't have a ton of time, but I'd love to get your feedback with the time that we do have. And I'll just go ahead and get started. So what do you know about the CAC and the role of the Community Advisory Council? If 2 or 3 people would like to respond, what do you know about the Community Advisory Council and the role of it? Now it's kind of a broad question. What do you see as the purpose of the Community Advisory Council?
I'll take a stab.
Yeah, okay.
Hey, Tammy.
I'm sorry, Justin, go ahead.
No, you're way better at this. You do it.
Tammy, then Justin.
Well, let me show you how it's not done. So, first you step on one of your partners. So, I really appreciate your honest statement of that the connection could certainly be stronger. And I'm really excited. I don't think that it's any intention that wasn't there to do that, but I really appreciate leading with that. And so it's meant to really be the soul of the community, sharing with us the ability of what maybe the essence of impacts, unintended consequences, things that need to be addressed, sort of the eyes and ears and the heart of the community to know the right direction for us to be focusing, and the things that are working well and things that are not. So I would start with that.
Okay, thanks, Tammy. Justin?
Yeah, I would just say the same thing. Most advisory groups for boards are designed to be the voice of the customer, and the concept being, that you effectively have your finger on the pulse of the person who uses these programs, and yeah, some of it, a large portion of it is healthcare dollars, but a significant portion of it isn't. And so, I think I think the fact that you're raising it is a terrific, it's really terrific, because I think a lot of times what we're doing may not really be completely dialed into what the end user of this program lives with. And so I think that should be the, in my opinion, I'm just giving you my opinion, but in my opinion, the outcomes of everything this group does impacts your group. So you are really the voting member who says, was it effective or not? And if the service isn't that great, or there's a lot of, if we have a great idea that we want to put money and effort behind, but your recipients are saying, boy, I could care less about that. Well, boy, I think that's the voice that we need to start hearing a lot more of. So I really appreciate you bringing it up, and that would be my 2 cents on the purpose of your advisory group.
Thank you. Appreciate that.
And
Anybody else? One other person you'd like to?
Justin said more eloquently where I was headed is, I think that is actually, healthcare can be an echo chamber. There's this highly technical, highly exclusive language that's used, and it's very obscure what we talk about. And, even our spouses roll their eyes and walk out of the room. My wife still talks about the white paper, which there was a white paper written 10 years ago. And
I still have it.
and that's what the health council is to her, and so the problem with that is that all that is very exclusive, and then we have no idea what this, we can be totally missing the mark. And how would we know? Because we're just talking to ourselves. So I think that's really what we're looking for ideally from the CAC.
And Gary?
Yeah, I was just going to comment that I would almost turn the question around too. You're asking, what do we as the board expect from an advisory council, I guess. But I would also turn that around. What does the advisory council expect from the board? And I wasn't part of the strategic planning that we had, and obviously there was a CAC representative, well, there were CAC representatives, but do they think that the strategic plan is in alignment with their priorities and objectives? So I would turn some questions back to them so that we could better align with their expectations.
Okay, fair enough. We probably won't get to that today, but that sounds like a pretty good next step.
Yeah, but that is a really good point, Brad. Yeah. Like that would be in any other board. Your group is the customer. You're the voice, and so if our entire next 5-year plan is aligned around the healthcare community's objectives or the board's objectives, and you guys look at that and say, well, that's not the patient's objective, that's not the user's objective, that's not the community objective. Well, boy, those glaring areas of disagreement would be great to call out or highlight, because I think everybody would like Rick said, you don't want to get too trapped in your own chamber. So.
Brad, this is Megan. One thing too that I think is helpful from a CAC perspective is with those goals and that vision, having the input of, what are the barriers, where are the gaps, what are the holes that need to be filled for us to achieve those goals and that vision from a very practical lived experience perspective. Because we don't have those inputs, then we might have some blind spots that get in the way of us actually achieving those goals. So I think that would be another really important role and input from the CAC.
Okay. And I'm wondering if, does anybody have, oh, go ahead, Patty.
Commissioner Dare.
Thank you so much. I actually started my morning out going to the vaccination center in at the fairgrounds, talking to people, why they're there, people that were working. Everyone is really talking about, okay, how can we get to that herd immunity? But honestly, I guess I'm kind of a practical person, and I remember our board had a retreat a couple of years ago when we were all together. And on the board, I couldn't see obesity anywhere on this board. And I'm going like, okay, from obesity, you get heart disease, you get diabetes, you have to have knee surgery, all these things that are obese. And we have such problems in our country. And then now with COVID, what is it? Over half the people who've died of COVID are obese. And I'm going like, why don't we just talk about this more on this group's level? I mean, really and truly, it seems that it could be incredibly impactful to the health of everybody in Deschutes County, everybody in our country on what do we do? Why aren't we really talking like make it basic? And so, you reach there, and then, also Brad, you realize that I think it took the county longer than it should have to reach out to the Latino community, and because the COVID numbers were higher there, it seemed like it took us a couple of months to respond to the actual numbers. But when I see the COVID numbers, nobody still wants to talk about obesity. Now they just lowered the BMI to 25. It was 30. So apparently somebody is paying attention. But what is it? Why? How can we get our people healthier? And I appreciate you asking this question. So that's just how I saw it today. Talked to a dentist, retired dentist. He's there giving shots. He's like, we've got to get through this. Met all these people, and they're all like, we've got to get through this, but we've got to go forward. And how can we go forward on a healthier basis? So really, let's get real, people. Let's talk about obesity in America and how to get our people, walking more and eating less sugar.
Thanks, Patty. So my next question is, does anybody have has anybody had a good experience, or can you remember a time when the advisory council really played an important role to the board?
I think that I've appreciated when we've all come together and done the strategic thinking as a whole. And we've done that pre-COVID. And I found those days really valuable, or hours really valuable.
Ditto to what Megan just said. That ability to go from kind of the policy to the practical was really helpful, being in the room together and in small group discussions together.
And are you both referring to like the annual, one time a year? Is it just one time a year that the CAC and the board come together?
Correct.
Okay.
Brad, this is Iman. And this is probably more, I'm a new board member, so I don't have any experience actually with the CAC, but I have curiosity that maybe Donna or Dan, who now I think has joined us, if there are throughout the state CCOs that have well integrated or dynamic CACs where the voice of the customer is perhaps more integrated into the board. I just have curiosity around what good looks like and what we could learn from.
It's a good question. The little bit of outreach I've done, I've heard that the CACs are not very, and somebody correct me if you've got other information, please, but I've heard that they're not really very instrumental, and even some regions don't have a CAC. Is that correct?
I think every region is required to have a CAC, but I would say that there's no region that's doing a bang up job and everybody wants to look at and follow. I think that the state continues to try to give technical assistance where they feel it's important. I think, Linda, you might be able to speak to that, but really trying to get our CACs kind of off the mark. And I think part of the problem is actually exactly what we're talking about right now is, defining much more clearly what it is that the CAC and the board need from one another. And that's exactly why we're having that conversation right now. And just letting you know, it's a little bit information of what's coming down for our retreat this year. So just so you know. So Linda, I didn't know if you wanted to speak to that question.
Sure, I'd be happy to. For the last 6 months, I think, I've been participating on a state-sponsored facilitated leadership collaborative. And the focus has been taking CAC members and educating them about governance and what sorts of policies boards should have. And at the end of every session, there's some homework to go back to your health council board and find this particular document if it exists, or have a conversation with your health director. So I think because of the nature of the beast, there's frequent turnover, and there are people who have not spent much, if any, time in a corporate boardroom. And so part of it has been building comfort with everyone. What is a board? What's the CAC's role? How can we empower people on the CAC to be conversant on issues? And so for me, it raises a question, not just what does the Health Council want to hear from CAC, but also what are the things that we believe CAC should know about to provide an invitation or an education, so that we're not overwhelming with acronyms, or they're not surprised by a particular issue that we've been talking about as providers, but we have missed the boat on, or if they understood or had an opportunity to connect, more understanding would happen. I do have to say that at the last CAC meeting, I came home from that meeting particularly excited because the CAC, we have some new CAC members, and they're finding their ground and they're starting to speak up. And so staff led us through a process of identifying what is an emerging issue. When we hear testimony, or we've had one CAC member's experience with frustration in filing a report or a complaint or language, whatever the issue is, how do we discern whether that's just an individual's issue, or is that a broader system issue that needs to be brought forward? And so I'm hopeful that in the next couple of months, as CAC defines its own process for what issues float to the top that then need to come to this board, that we'll be able to start to hear the kind of information that we want to hear, and that CAC is the only one capable of delivering to us.
Thanks, Linda. Yeah, when you started out, it was like, great, governance. That's not very exciting. I like the emerging issues. Yes, Dan.
Hey, thanks for bringing this forward. I agree with really good insights people are sharing. I'm not sure if this fits one within your first question or your second one better, but one of the things, if somebody on the street said, hey, what does the CAC do relative to the Health Council work, and how does it interface and really leverage its voice? There's two things that I always say right off the bat that I think a lot of people get, which is, wow, the CAC is really instrumental in our community health assessment work, and therefore our community health improvement plan, or in our case, regional health assessment, regional health improvement plan. There's probably always an opportunity to leverage their work better on that. But that feels like a really strong deliverable that they've been a big part of, and historically, and super important to make sure that sort of the voice of the region is reflected in both of those documents. That's kind of our playbook for health improvement, right? The other one is on non-traditional benefits or flex funds. The CAC has played a really big role in that, and really helping guide the efforts of the CCO to what does it make sense to pay for or give people an opportunity to improve their health around that isn't traditionally covered by the state benefit design. So those are two areas that have always felt pretty concrete to me. But again, maybe the CAC would say, yeah, here's ways we could, that you could leverage our voice even better on that. So.
Thanks, Dan.
So, Brad, I think what I wanted to add was the feedback that Linda gave and thinking about the turnover is that having stuff in writing, maybe not as dense as a policy book, but purposes, goals, processes about how to do the work, and as a way of introducing level setting for everybody who's on the CAC. And if those exist, maybe taking a look at them again and making sure that they're up to date and alive documents. So that may be a process to sort of deal with the lack of historical people there. Linda, you went off mute.
I'm off mute. Should I be on mute? Rick, as you were speaking, I didn't space out, but I suddenly went into this place of what can we as a council do to show our direct appreciation for the participation of CAC members, not just once a year, but episodically, or, I've been on the CAC committee as a board representative for 3 years now, 3.5 years. And other than at our joint retreats, I'm not sure I recall this board expressing direct appreciation for their input on much of anything. And everyone loves to be appreciated. So we might want to think about some intentionality around that.
Thanks. Do we have time for one more question?
Sure, go for it. This is productive.
Yeah. Okay. Yeah, what difference would a stronger CAC advisory role make to the board and to the whole process, the whole CCO? What difference would a strong CAC make? What would that look like to board members?
I'd like to jump into that one. Being in a room of health professionals who have spent our entire lives designing solutions, being very collaborative, being patient focused. I also know that the best systems sometimes have cracks in them. And that if we can't have a strong CAC that comes and says, yes, I know you have a dispute resolution process, but it's breaking down in this way, we'll continue to put out a bad process. We critically need that feedback from the non-provider client, if you will, the receiver of the service. It's critical to our success.
Anybody else? Thanks, Linda. Again, what difference would a strong community advisory council make to the board and the overall process of improving health in Central
I think there's probably a pretty high probability that if it worked appropriately, it would really help us get to consensus quicker. If the community is letting us know that there's a service or a need that isn't met, or a service that doesn't operate very well, or the end user experiences something pretty poor associated with this program, I think, kind of the vote's in, being defensive then at that point as a health system or a provider is pretty much over with. If the customer is telling you it's a pretty poor service and a pretty poor delivery, then you can argue about it, but ultimately you're the end user, and that's what matters. So I would hope that if it worked effectively, you could help us really move decision making much faster, and things would get done much quicker if everyone knew that the items we were working on were universally supported as the top items that you care about as the end user. And if you were saying there's a problem, boy, I would hope that would be a reason for all of us to get in a room and try to figure it out a lot quicker.
And the other
I completely agree with that. And I think that on the flip side, a really critical role that CAC can also play is in good partnership with the provider side in being that conduit of communication, why sometimes providers do or say the things that they do, and how can they help and facilitate greater patient engagement also. So kind of from both sides, I think can be a really important role in guiding as to how do we communicate. And when I say we, I mean like from the provider side, you know, why sometimes, you know, certain things feel a certain way, or, you know, why those are important. Why, if, I mean, I'm just going to make a silly example of like why it is important for you to always bring your pill bottles, for example. Like it's for your benefit. Like there's some of that communication that can also, the education piece that can go on both sides. Providers can be better educated on meeting the needs of the patients, and the patients can be better educated on, you know, what, like why that engagement and how we engage and what, how to make the most out of their visits, for example.
Okay. Thanks. Anybody else? One last comment regarding what difference a great community advisory council would make?
Brad, I have a question. I was just noticing the March meeting notes attached, and I was just wondering, Jefferson County's person was missing. Tom Kuhn wasn't on the call at that meeting. Neither was someone from Klamath and Crook. And I just wondered, is that historically what happens, or was it that just that one meeting that it was you miss? I think some key people.
Yeah, I don't think I can answer that, Patty, but the staff should be able to.
A lot of this is Michaela Arsenault, a lot of the county representatives are heavily involved with COVID response. And so that's why they aren't able to attend as frequent.
Should the county then had someone else go in and, as an alternate though? Because it is an important group and you do need the feedback.
Patty, the capacity of the small systems in the small counties, there typically isn't somebody who can be backup.
Okay.
There's just not enough staff.
But Deschutes County, I mean, Tom wasn't there. I mean, I know Tom's very responsible and everything, but you know, when I saw his name missing, I just was wondering.
And I think just in general, I think we, and I can't speak for the county representatives specifically, but to have good participation, engagement, retention of CAC members, especially the consumer representatives, we need to be doing something that matters. So that's kind of the goal. So I appreciate all your feedback. I'll take this back to, hopefully the staff got notes, but I got some pretty good notes as well from everything everybody contributed. I'll take this back to the CAC, and then we'll pick up on the what does the CAC expect from the board question that Gary raised. Thanks, everybody.
Thank you, Brad. That was very productive. That was very, very productive. Thank you very much. How I'm going to circle back is I'm going to do the ops chair quarterly report out first, and then we'll go back to the policy book discussion and vote. I just wanted to respect Emily Solomon and her maybe needing to do something else other than sit in our meeting and listen to a discussion on our board policy book. I don't know. I know that would be riveting for you, Emily, but so you can stay if you want to hear that discussion.
Thank you.
But Emily, Ops Chair's report out.
Thanks for having me this afternoon. Can you guys hear me okay?
You're a little quiet, so talk loud. Do your outside voice a bit.
Okay, if at any time there's an issue, please just wave at me. I actually co-chair the Operations Council and the QUIM work group with Janice Garceau. So it's a shared chairpersonship. And I'm here today to do a summary of the 2020 and 2021 regional QUIMs. You can go ahead and, oh, there's some graphics in there I didn't realize. Thanks. Just a quick overview of what I'm going to go over. And I do want this to be meaningful for everyone. So stop me if you have a question or if you have feedback at the end of how we can do better next time. I'd really love to hear that. I'll do a quick high-level review of attribution and service providers in the QUIMs, the 2020 and 2021 QUIM summary, some targeted efforts that Pacific Source is partnering with us on, and then can take any questions. Are we still okay for 20 minutes from a time perspective, or would you like me to adjust? Okay. All right. The first item of note here is the change in attribution from 2020 to 2021, I believe primarily as a result of the suspension of redeterminations due to the public health emergency. And so you can see our regional enrollment was about 48,000, 49,000 in 2020. We saw about a 21% increase into this year, sitting at around 59,000. Of course, at any time, these numbers change a little bit, but I believe these to be current and accurate. And Teresa McIntyre is my partner in this also, so I want to invite her comments as we move through. I've listed.
Yeah, Emily, just a quick point on this one. This was just looking at the top 10 enrollment clinics.
Oh.
So it would not represent the entire, but these are the clinics with the top attribution or enrollment.
Okay. And the clinics that you see listed on this slide carry the majority of that enrollment. And the reason that that's important, and it's not to play down the role of every clinic in our CCO, but the reason that these clinics are extremely important is because really to perform well as a region, all of these clinics need to perform well because we carry the bulk of the lives in the region. Moving into the next slide, the slide before was our PCP attribution. So when we look at performance, we're looking at PCP clinics. However, it's really important that we know this is truly a community system that works together to perform well on the QUIM. So all of our dental providers, drug and alcohol treatment providers, community mental health providers, public health agencies, emergency departments, and Pacific Source. We can get hung up on the role of primary care because that's how the lives are attributed. But to be successful, everybody has to be engaged and working together to integrate their services in a way that works for the people that we're serving. So in 2020, as we all know, we had COVID snuck into our periphery, and we saw a massive pivot to a COVID-19 response, really by every provider in the region. We, as a result, thankfully saw the measures move to a reporting only status. And so while we continue to work towards meeting the targets, many of those efforts were impacted by COVID, and thankfully there were not huge disruptions to our payments and the setup as a result. In addition to pivoting medical and social service response, we were working with a public who were socially isolating. They did not want to seek care. One study out of the University of Oregon around well-child visits showed in May of last year that I want to say it was about 75% of the thousands of households they'd talked to across the country had indicated that they had not gone to or had intentionally missed their well-child check because they did not want to go in. So we saw there was a lot of evidence around what was happening as a result of COVID. The consequences of that to the performance on the QUIMs was childhood and adolescent immunization rates stagnated or plummeted. We saw that across the country. I'm sure many of you saw national articles about fears around the ground that was lost there. We had dental measures that had been introduced in 2019, had not gained much momentum, and then we really lost any little momentum that we did have in 2020. And again, we saw well-child visit rates plummet. And in the QIMS, those well-child visits, you know, they're just so closely correlated with how we do on immunizations, as well as just keeping kids safe, that it was really troublesome, frankly, and something that the QIM work group tossed around and tried to get creative about in 2020. On the flip side, we did have some favorable things happen with regard to the QIMS, and I want to make sure that I'm clear here that we often talk about the metric and we talk about the mission, and sometimes favorable things can happen to the metric, but it makes us concerned about what's happening in the mission. And EDUs for people living with mental illness is one of those things. When ED use plummeted as a result of COVID, that was good for us from a metric perspective because lower is better, and we went really low and we looked good on that. What we were all worried about was, where are all these people going and are they getting the care that they need? And as we've talked about this, you know, since then, I think that, you know, having a crisis stabilization center that came up during this pandemic was a really good thing. And we think that that may be hopefully where some of this utilization went. Postpartum care also benefited from a measure specification change. The measure widened quite broadly what would be included in postpartum care and eligible to meet that measure. And the target was still set based on the rate from before. So we'll see, you can see in the reports that our postpartum care performance is way off the charts, and that has to do with the change in measure specification. And lastly, a big win was, despite it being new in the set, initiation and engagement of alcohol and other substance use, that measure, we did see clinics put workflows in place, and we did start to see some early returns on those workflows. There was on the QIM work group and the Ops Council, a lot of conversation and energy given to health-related social needs and other environmental circumstances that were happening. During this time, we worked on the Intimate Partner Violence Toolkit, and that was the result of people coming together and saying, I'm worried that these things are happening for my patients and we're not seeing it anymore. We had heard from a member of the High Desert ESD about teachers' concerns about kids not being in school and teachers not being able to get their eyes on them and their safety. And so in addition to the work on the QIMS, that QIM work group and the Ops Council was able to go after a couple of those things as a result. I just wanted to put this cover sheet from the 2020. These are not final rates. We're getting close, but we're not there. We don't need to go through each one. I wanted you to have the cover sheet. I believe you have access to the full report. We can pull it up if you have questions and want to dig deeper. As you can see, the measures on here, only 3 of them are in a passing place. The remainder are not. What you're not seeing on here are the measures that are reported through electronic health records. We call them the electronic clinical quality measures, or ECQMs. And those, you don't see those on here, but those had similar performance. So coming into 2021, this is our list of the quality incentive measures. No change from the year prior, with the exception of the number 14 there, the meaningful language access measure. That is a reporting from the CCO measure this year, but we'll come to that later. What I do want to point out on this 2021 list of measures is those with an asterisk at the end. So number 3, number 2, number 12, and number 10, sorry, I could have done that in order, 2, 3, 10, and 12 are also challenge pool measures, meaning presumably, assuming not every CCO makes their money, there will be an extra little bucket of money available to be doled out to those who meet the targets on those challenge pool measures. As an added layer, let me gotta check my notes here. 3 of those, which are numbers 2, adolescent immunizations, 3, well child visits, and 12, initiation and engagement, are also provider contract measures for the surplus. So we're seeing really good alignment and higher stakes, more at risk for those measures. This year, the conditions for those working on these measures, we're seeing the COVID-19 response has now pivoted to vaccination efforts. A really important thing here is St. Charles and Mosaic especially have diverted a lot of their workforce and energy to getting the community vaccinated. They're also 2 of the largest clinics. So those 2 groups need to perform well in order for the region to perform well. And they're also working on COVID vaccination. So they're balancing a lot right now. We're starting farther behind on many measures as a result of 2020's lack of performance, and that payment mechanism for incentives is back in place this year. In the current state for the measures, ED use for those living with mental illness remains low. Again, lower is better, but we want to make sure that these people are getting the care that they need. We have immunization measures that are going to be pretty tough to come back from. Those measures build on each other year over year, the way that the measure specification is written. And when you lose ground in one year, you lose ground in future years because of the timing of the immunization schedule. The CLIM work group is really putting a focus on reducing disparities in health outcomes across all people and all groups in our communities. And that's, we hope will, we know it will make us better as a community, and we believe it will help our performance on these measures. We've also have new efforts aligning the CLIM work group more closely with the Regional Health Improvement Plan work groups, as there's a lot of crossover in the CLIMs and the work groups. Our dental measures need focus. Those are integration efforts between primary care and dental care, which takes a lot of time. And then we need to be talking about our language access measure for future years. It will only be in reporting for 1 year, and we need to be building competency and capability, not only for the measure, but for our communities. I threw a couple of, you know, I picked a couple to show you all, but truly, if you want to see something else or have a question about a different measure, please let me know. What you're seeing right now is the childhood immunization measure. And I think what's notable about this is one, you can see how the performance trends every year, but look at where we're starting and look where we have to get. And I'll spare you the granularity of the measure, but this is going to be a challenge. And I think is, you know, arguably one of the most important things we can do for public health and the health of our communities. So just wanted to bring some awareness to this for you all. You can see we're starting at a rate that's close, more in line with where we were in 2016. For adolescent immunization, same thing. You can see we're starting at, you know, about 23%. And last year we started at 26. We've actually seen a downward start year over year in the adolescent immunizations. So you know, just a lot of ground to cover. And then the dental measures I wanted to call out, because you can see we're starting similar to where we did in 2020, but we're a little bit off the mark from where we went last year. And it is very early in the year, and it's too early to make any conclusions. But I do think these are call to actions for us if we want to hit these targets this year. Pacific Source is right by our side through all of this work and does a lot of outreach and leverage learnings and helping the QUIM work group and the providers along the way. I've included, Teresa actually provided this for us, the efforts that are currently underway or planned underway, and wanted to make sure that you guys had these for awareness or questions. I won't read it to you, but if you see one you have a question about, let me know. And happy to take questions. Like I said, we also have the 2020 full report and the 2021 full report if there's any questions you have on any specific measures.
Emily, if I could just chime in just a little bit here, if that's okay. I think, you know, while it's, you know, the data that you saw was through the end of February. So, you know, we don't have the full first quarter of data, but I can say that that, you know, we have some concerns around meeting these metrics. And I think part of, I guess, the question that I would like to ask here or to maybe bring up is, you know, what might be able to do both within our clinics, as you know, for the Health Council to do a deeper dive into some of these metrics where we're really struggling and try to figure out how we can put some more attention on those. I know that our attention is quite diverted right now, and particularly as Emily noted with St. Charles standing up helping to stand up one of the best vaccination clinics in the state, and that's really important work. And Mosaic's attention is diverted there as well. But we have some real concerns, I think, around these metrics this year. So I just want to throw that out there.
I'm curious if you guys have had conversation at ops, because I think there's also some great minds at ops that, you know, where we can really think operationally, you know, how we can, you know, move the dial more significantly over this next year and make sure that we are tracking together and not working in silos. So I'm curious if there's sort of discussion or thinking or ideas from an ops perspective about how to kind of move us forward.
Yeah, thanks, Megan. That's a great question. We do review this at ops and have some level of conversation, albeit it's not always as engaged and granular perhaps as we would hope for. We have been trying to change our approach and how we discuss these things at ops to drive engagement, but I think we're still trying to learn how to do that better. For many people, these are things that we've worked on for year after year after year. And I think that sometimes it's just hard to see outside of where you've been for so long. And so getting fresh eyes and new perspectives to the table has been valuable. In fact, Summit Health just recently asked if a couple different people from their organization could attend the QUIM work group. And so we'll, and you know, they're more than welcome to join, you know, as our guests there, and in the hopes that they have a perspective or an idea that we haven't come up with. And that stands for anybody. So the QUIM work group has the majority of people that carry Medicaid lives meeting there to talk about these measures and to brainstorm and learn from one another. And then we take a subset of that conversation to the larger Ops Council to talk about that. But if there are new perspectives that we can get to the table either at the granular level of work group or at the higher level of Ops, we welcome that, and just reach out to Michaela and let's see what we can do to get those ideas there.
You know, the only thing I would add is I don't want to, you know, I don't want to minimize the hard work that everybody is doing and doing the best that they can, given kind of this weird place we are in, kind of one foot still very much in the pandemic world, one foot hopefully stepping out of it. And some of these measures are, I mean, the biggest challenge with all of this is the age restrictions. And so some things, there's just no control over what gets people, you know, if people age out, there's just no catch up that one can do. And so I think that is the biggest challenge. And I do believe, you know, from our conversations, we're pretty actively engaged with a lot of the clinics. They are not kind of sitting on their laurels. They really are trying and are working really, really hard. I think that the challenge again is kind of the same thing that CCO in general faces, which is rules that we still don't even know what they're going to become 4 months from now, potentially, or 5 months from now. And kind of these changing rules and the decisions that get made from the state fairly late in the year too. So I just want to acknowledge that, that it's just really, really difficult, but that everybody really is putting in really good faith effort in doing the best. And we'll continue to think creatively in any which way that can be supported.
Emily, this is Iman. Just kind of carrying from Megan's question around what are, you know, kind of the best thinkers at Ops Council recommending. How is COVID continuing to impact our performance around the measures, and how can someone like me who does sit on the CCO scoring and metric council kind of bring that forward as we approach the June deadline for reevaluation of performance expectations?
Yeah, thanks, Aman. You know, I was just sitting here thinking that I think COVID has delivered us a really big and beautiful design challenge, frankly. Like, this is all about how we design our healthcare system. And what we are now having to design for is some fear in our community, some lack of engagement because there is concern about their health in light of a pandemic. And so also, like I think we saw with the vaccination efforts, having more mindfulness around designing for people, you know, specifically that are older. And I know that doesn't come up with the CCO quite as much, but I think that it's really important to remember that we can go back to the drawing board and redesign and transform the system in a way that works for people. But if people aren't comfortable coming in and we don't have a system that can go to them, we're stuck. And sometimes the way we have to encounter our work for the measures requires us that we be one place or another. And if the patients don't want to be there, our community doesn't want to be there, it's tough. So.
Yeah. It kind of, it makes me think that some public service announcements across, you know, Mosaic, Summit BMC, St. Charles, the full, you know, full on press effort to kind of get back to basics when it comes to get your vaccines and go to primary care, you know, your doctor misses you. Just something that can encourage people to get back in. Cause I mean, we're definitely seeing the byproduct of people probably not getting the best primary care by what we're seeing in our emergency departments and our overall admissions to the hospitals, because we're definitely full across the region, across all 4 hospitals. Like all this week, all 4 hospitals were what we call capacity red, in that the beds are full and they're not full of COVID patients. You know, we had 5 COVID inpatients today at the Bend Hospital. So what they're sick with are things that are completely, I think, well, largely manageable on an outpatient basis if we do good primary care. So anyway, I just say that because we're in this together as a region, and we all, I think, have our unique work. But I also think that there are some commonalities that we're facing, as Emily speaks to, which is a resistance to probably engage like they used to with their childhood immunization times and going to the dentist and all of these things. So just wanted to add that.
Megan?
Yeah, it's Gary Allen. I'll just comment, for the preventive dental metrics, it's really all about the schools. And with even with the schools going to some in-person living or teaching, they're not necessarily allowing hygienists to come in and to do the preventive services that we've traditionally done. We can pivot and redeploy our workforce, but we have to have the membership pivot with us and access the services through our dental clinics or other strategic sites, since that they're really not going to be able to get it at the schools.
Megan?
I want to tag on to what Iman was saying, and I was actually talking with Steve Strang and his vaccine hat yesterday with the county, that I'm wondering if there's like an opportunity to do like some kind of a campaign, because campaigns in healthcare actually do move the dial on whatever you're focused on. And if there could be a community campaign about vaccinations, I think we're not seeing that. We're not filling the vaccine schedules, but then also about getting people back into care and really make that a thing within Central Oregon and start measuring and sharing the numbers. And you could even like post numbers. I remember like United Way campaigns, like they post the numbers, are they at their goal? And I'm just curious if there is an opportunity to do something like that across Central Oregon because of our geographic isolation and our size that could be really meaningful.
I'd love to say something. Yes, definitely the county can probably help with billboards, et cetera. I've been saying this for months that people need to see their doctor. You can't just not see your doctor for a year and a half. And I love that idea, Megan, having the chart up. Okay, so we are like at the top of the state for our COVID vaccinations. It's unbelievable how well we're doing, but let's remind parents that, hey, your kids definitely need their vaccines. Billboards, public service announcements. I'll definitely share that with Whitney, that these numbers are quite frightening. I know we have a huge anti-vax population here, but this is way beyond that. So it sounds like we're going to need a lot of re-education for our community. I really don't want to bring back some of those horrible things that I got to deal with as a child.
So, and I would, with my behavioral health hat on, I know those services in behavioral health that we had to go to virtually all virtual, our outcomes have plummeted, and they will stay bad until we can get higher rates of in-person services. So I suspect the same is with primary care. I think doctors like to think technical, but I think the relationship is a big deal about the outcomes. And if you're doing your primary care call through a FaceTime, then just doesn't do the trick as well. So I think those dynamics are playing out throughout the system. So I think what people are talking about around a campaign about, and I don't know how far along the primary care system is about opening the doors to in-person care, but I think that is critical to moving this forward, and certainly is in behavioral health until we're able to we're doing some in-person care, but until we can get to do that full-fledged, our outcomes are not going to be great.
I'll throw this out there, just not because we need to solve it today, but I think about how much leverage we will have as we start to vaccinate everyone 16 and over, and how many parents we will have hopefully coming to be vaccinated, and how might we connect better with people and their families through these vaccination efforts. If kids are behind on their vaccinations or need a vaccination, how might we give them a vaccination when we're doing our COVID vaccination for parents? It does a couple things. It makes it more convenient. I think we're going to have a lot more kids coming through the MassVac site in the coming weeks. So just a thought as we think about a campaign. I know it's logistically challenging, but I think this is where we're at, is we have to push ourselves to get creative. I see Mitchell has a hand up.
Yeah, sorry, I don't know how the forum really works or anything. I'm just kind of observing, but as I've been listening to you guys, I just had one question that kind of popped in my head, especially related to primary care and the availability. Just a quick history of myself. I worked in a primary care clinic as a nurse in the east side of Portland for 4 years. So I have a pretty good idea of at least how the Kaiser Permanente primary care system works. But my question more relates to how the mass exodus of actual healthcare staff from healthcare. Do you guys have you guys had any discussions on addressing that? Because as a union representative now, and now that I've got like a full scope of everything, there just seems to be a lot less boots on the ground to actually, do this kind of primary patient care type work, right? So I just wanted to ask that question. If there's no answer, that's fine. But I just wanted to kind of bring that to your guys' forefront and see if there was anything that you guys had discussed.
This is Cindy. From Summit Health, I would say that's a really good point. I mean, we are struggling to find MA help. They're just, it's the cost of living here is part of that problem, but it's becoming pretty widespread.
Statewide in behavioral health, workforce is our #1 strategic problem. And it's big here in Central Oregon too. So big challenge. And we've made it a big focus at the legislature. So I know that wasn't really your aim, Mitchell, but it is very much a thing in behavioral health. Any other comments about the QIM, the ops chair report out?
Rick, this is Teresa. I just had one question, if I could just pose to the group that, what we're hearing is that, at least in some of our larger clinics, that of course a lot of their attention is diverted right now to vaccines and as it should be, but a lot of the staff that were previously doing quality work or population health work in the clinic are now devoting their time to, doing outreach and calling people to get them scheduled and, manning the sites and those sorts of things. So I think one of my questions would be is, what would the clinics need to divert some of their attention back to some of the quality work? And I know that's not something we can answer in a couple of minutes, but I just wanted to throw that out there to see if it's something we could think about.
Probably 80% vaccination rates in the community. I don't know. But I'll let the clinics answer it from their perspective. Megan?
Well, I think for us, what we're looking at is creating a temporary staffing model to run the vaccine clinics, because it's a large amount of work. This is different from other types of vaccines. And so we're looking at hiring a temporary set of staff to run that so that we can focus the staff that are in the regular day-to-day care back to those areas that we need to do as well. So that's a strategy that we're looking at.
And I would just be concerned that the vaccination efforts are showing signs of getting overwhelmed. I know my wife spent a week trying to get an appointment, finally did get one, 61-year-old woman with plenty of pre-existing conditions. And so from the end user perspective, there's apparently a lot of demand and hard to get in. And then if you're saying there's unfilled slots, that's just telling you about bottlenecks and problems in the system that become very frustrating to achieving, and then if you open it up to everybody, all those issues will get worse.
Yeah, I think there's some folks that are really struggling with the current systems to get a vaccination. I had probably 8 people today that I got a list that couldn't get through the systems and just really needed some help at both Mosaic and the county. And so I think there's something there with the body of people that the current way is not working for them for whatever reason that I think we need to learn a little bit more about. But that's kind of a different topic
yeah.
But I pass that on to Steve.
Yeah, okay. Other questions? Very good presentation, Emily. I think that was very helpful and very grounding in what we're doing. Thank you. Thank you very much.
Thanks, everyone.
And you can stay for the policy book discussion. It is riveting, I can assure you.
I know it is, and I have another meeting, but don't
liar.
take that the wrong way.
Liar. Okay.
Yeah, thanks again.
So Linda, we wanted to circle back on the board policy book. So Dan, we had talked about it to some extent and sort of answered various people's questions, but you weren't on yet. And so then I delayed completion of that discussion and any vote for you to come on, in part because of your unique position within the board. And so wanted to circle back on that again, and then ask if you had any questions or concerns or things that we should consider with what we have in front of us.
Thanks, Rick. Was that for me or the governance committee?
That was for you, Dan.
Okay.
But if Linda or anyone on the governance committee wants to jump in, then feel free.
And this is Linda. Dan, I just shared with the board what I shared with you by email last night. It's sort of the continuum piece and what the governance committee's policy deliberations were around, and sort of the background on what was presented today.
Okay, fair. Sorry, I missed that. I was trying to get in by mobile phone and apparently I was missing a code. So I know I jumped right on when Brad was in there. So apologies for missing that.
Did you have any ongoing concerns that you wanted to share with the governance committee or with the board that should be addressed before we vote for approval or not?
I think that I think there is a best practice. This is consistent with the feedback that I sent to Linda, which I think, Linda, you brought to the governance committee. And I know you decided to kind of keep it. I just think that when a policy manual introduces terms that are really meaningful terms, such as board governance or policy governance, we should define those terms just as a matter of best practice. So we're referencing policy governance, but we're not defining it. And so it's kind of left to be defined by the reader or somebody who's interpreting the board policy manual. And I just think that term is a term worth defining. So that was my feedback. And I know the governance committee discussed that and decided not to go further with that. So I'm still kind of discerning over that. To me, it's not acceptable, but I know I'm probably in the minority.
Dan, we talked about, before you came on the call, about that continuance with the Carver model at one end and a scintilla of a policy-based governance system at the other end, and that as a board, we're not at either extreme, that we're sort of somewhere on that continuum. And so if you have a definition that would help us describe that piece of it, I think it might be really helpful. I mean, we can pull up a Carver book and get the one extreme of the continuum, which we've all agreed at many meetings, this is not. But what we're struggling with is sort of where are we in the continuum of those two extremes?
Right. I think the continuum is a good term and a good framework. I think the concern that I was trying to express is when you use policy governance, for a lot of people, it implies full Carver. And if you Google policy governance, the first 10 or so references that come up are Carver. So without being more clear about where we are in the continuum, I think people's default goes all the way over there. And that was my concern. It isn't so much that I think somebody's trying to be sneaky or we're going to all of a sudden start to do full Carver next month, but we're also, not all of us will be on the board, next year and the year after and the year after. So I think I can get there, but I know that we're trying to set this document up in a really thoughtful way. So
Megan?
One thing I'm curious, Linda, is could that be helped with this not being called a board policy manual and it's a board guideline manual or board best practice manual or something, so that it doesn't, and I have functioned on a board with true Carver, and I think there's pros and cons to that. And if we were ever to go onto that side of the continuum, I think we need to really, really, really talk about that as a board. And that organization is no longer in existence. So I think that I'm wondering if maybe there's some language change that could take that potential misperception off the table. So then it really is this document that is at the right level for this board to guide our work and create really good role clarity around our different roles.
A great suggestion, Megan. I'm wondering if it would be helpful if we just write a paragraph that describes that continuum idea and states clearly that as the board evolves, we may move one way or another, but this is our core integrity. And I personally don't have a problem with policy books, because whether you're Carver or not Carver, policies are just sort of a universal language, unaffiliated with those from my perspective. So I think rather than change the name of the policy book, I might suggest a paragraph that describes where we are and where we're not. Would that be helpful?
Yeah, so I would have a couple of comments, not for the final solution, but as a process. One, it's a policy book, so all we have to do to change it is to vote next month, right? This is not bylaws. This is just a set of policies. And partly driven by, so I, as board chair, know what the heck I'm supposed to do. So that's one. And then just a personal editorial. If this board ever decided to go to full Carver, you'd have to find a new chair right away, because Dan, how I operate will not fit well with that. So I think what I would be asking for the board is, I don't think there's anything lost to wait another month and try to get a language or a definition for that. Or we could also vote with an understanding that in the next month, we're not going to go to full Carver anyways, and we can work toward getting a definition built in next month. So either way works for me. I think the outcome is the same. So I'm just trying to find a process to the end. I think having a definition for that, whatever that would look like, I think would be wise. And I don't have an opinion of what that definition would look like, but we can work in the next month to um, for people who specialize in this stuff to come up with a definition. So I'm just trying to think of a process to get us through the next step.
And I'm open to working in any way that we can so that everyone feels comfortable voting to support this.
And there's a couple comments in the chat from Tammy and Iman.
Right.
Additional suggestions.
Right. So what Tammy said is, I agree the language is critical. What if we use protocols, practice, agreements? And maybe, and Iman says maybe board procedure manual, get away from policy that alludes to rules or bylaws. So we're in agreement that whatever we use, we should use a P word, protocols, practice, or procedures. So that's good.
Dan, do you feel that changing the name of the manual will solve the conundrum, or are you feeling more of a paragraph that's more descriptive would be helpful? What are your thoughts on that?
For me personally, no, it's not about the name. I think I agree with what Rick said there. It's about, again, it's about introducing a term that's really meaningful to this document and how we are saying we want to operate, but not saying where in that continuum we are, or defining the term. That was my contention. And the rest of the document is beautiful. It's really a product of great work. This is just that piece.
So I think, again, Linda, is there any opposition to one or the other in the next month working to present a proposed definition by next month?
Not at all. I would even invite a small work group, maybe Donna and I, or Kelsey and Dan and Megan, maybe put our heads together on emails, and I could start a draft and we could put together a paragraph or something like that that would meet the need for a better definition than we have today.
Okay, good. So I think we have consensus on that, and I'm glad as board chair to assign that to my vice chair to lead up. There I'm actually using my authority for once. And then I think the question mark for me is to get out of this topic area, should we table a vote on the policy book for one more month, or should with the as that work gets done, or should we vote on the policy book and then vote to amend it next month with the new paragraph? I think the outcome is the same. What would be the consensus of the board?
Perhaps I'm naive, but I don't see a downside of just tabling it.
Okay. Okay. We can table it. I think we've talked through the issues. We'd have to vote for it one way or the other next month. So no efficiency gained by taking the vote now. So we'll just table it one more month with the understanding that we have broad consensus on this, and we're just trying to add this one definition in there. And we'll take a final vote next month, and assuming that we'll have far less discussion about this. We're running out of time, so I want to prioritize a bit of stuff here. The CUSC, I know Divya had a long presentation that she had with the PowerPoint, but I think we'll delay that. You know, she wanted to fill up all that time, and I can assure you it was meaty and substantive. But we do have a small group meeting later this month too. So I think that would be more useful. Donna, do you want to talk about SB 741?
Yep, just really quickly, just wanted to let folks know that we had our hearing, then followed by a work session with a due pass recommendation. And just moments ago, I received notification of a second reading. So we are not expecting any opposition whatsoever, and it looks like we're good to go. So I'll keep you updated.
Okay, good. I think it would be useful to have the community partner satisfaction survey. So Kelsey?
Absolutely. I'm gonna share my screen here. The one pager that summarizes the satisfaction survey results is on page 32 in the board packet if you prefer to follow along that way. So I will walk you through the results, and then we'll have a little bit of discussion later on. Feel free to comment in the chat as what comes as a surprise as we walk through this. And thank you to all of you who took the community satisfaction survey. We released it about a month ago or so. It was open for 3 weeks. But I don't know which ones of you took it because it was anonymous, and that's probably the most important thing that's notable. We asked people how many years they had been participating with the Health Council, which county they were from, which sector they were represented, like healthcare, government. And the last one was whether they were representing a community partner organization or whether they were representing themselves as a community member. So why did we do it? We've never done one before and realized that we could use some quantitative and qualitative data on where we stand with our volunteers and why people bother to show up. We're so grateful that all 250 of you do, and we're hoping to put words to it in the near future. We want to know what people find positive or negative about working with the Health Council, and we intend to repeat this survey on an annual basis, so this year's results will serve as a baseline. Some of the benefits that also came after we did the survey was we realized that we learned better how to support our volunteers and identified some strengths that we didn't know we had. So we'll get to those in a minute. Yeah, like I said, we sent it to 250 plus members for a 41% response rate. We had a really strong turnout from our community members. That represents anecdotally what I would say is probably most of people who come to represent themselves, which really helped with the statistical relevance of their responses. And we want to hear from them because one of the big themes of the survey is reaching out to more of them. The pie chart section is exclusively from respondents who represent organizations. Almost over a third indicated that they've gained credibility and have become a trusted partner in the region. One of the themes from the survey was that the longer you've been with us, the more that you've gained from us. And that's not too much of a surprise. When we cross-sectioned the data, we found that half of people who have served with the Health Council for more than 4 years indicated that they have gained credibility and become a trusted partner in the region directly as a result of working with us. Out of all respondents from an organization, 70% said they've become more connected with organizations inside of their sector. Bonus fact on the side of that, 70% who have been with us more than 4 years say they have coordinated services with organizations outside of their sector as a result of working with us. And probably my favorite statistic of the survey is 95% agree their organization's opinions and recommendations are heard and respected by the COHC. Over half of all comments that came in from the survey mentioned some form of either lack of diversity, missing representation. It was not something that we didn't already know, but what we heard was that people are really ready for it and they're really hungry for more voices, a broader representation in 2 different ways. One, in a professional way. We heard loud and clear that the majority, not surprising, of our organization reps are from a healthcare background, and that there's a desire for the whole ecosystem that is Central Oregon to have some sort of footprint with the Health Council. The other lack of diversity that was pointed out was populations that are not well represented. This would include people of color or people with diverse abilities. We heard it loud and clear that there are populations whose interests are not being represented inside of the Health Council at this time that we need in order to make really well-rounded decisions. Which leads into the statistic you'll see that is from community members. Of the 13 community members who responded to the survey, just under half agree that their voices carry, either agree or strongly agree, that their voices carry as much weight as those representing organizations. And this is an important statistic as we invite more people to the table. People won't stay if they don't feel heard. And this gives us a baseline and tells us that we have some room for improvement on this part. The staff picked out a couple of quotes that we felt represented more of the whole of the plethora of comments. I'm not going to make you read 100 plus comments. These are the 4 that we've curated for you that we felt were indicative of the rest of the results. I'm going to pause here and ask if there are any questions from all of you. And I can't see everybody, so just unmute yourself.
Kelsey, it's Tammy. I'm just wondering, lifting from the original or the beginning conversation that we had with Brad and the CAC, I just wonder how strengthening the alignment between the community and the board may help to elevate voices that are feeling without that space right now.
I 100% agree with you. Most of our community members who participate with the Health Council are on the CAC in some way. Some are not. Some sit on a work group. I think that changes in the CAC would ripple in that that area greatly, and especially a stronger connection for the CAC's voice to the board would make a huge difference. Mm-hmm.
Kelsey, I'm curious about, again, kind of going back to this all kind of highlights, for me at least, something that says, who do we want to be and what are we? I mean, in terms of, is our role to be all things to everyone in a community beyond health? And if that's the case, then I totally agree with, we need to bring all voices from all sectors. Will that mess with possibly some, I mean, sometimes it's better to have a focus, sometimes it's not. And I don't know, where do we want to go with this? And so I just posed this question. I mean, are we going to, do we need to redefine who we are? Are we going to broaden it to, like I said, a bigger thing? And then if that's the case, then yeah, then we need to fundamentally really change the way we operate.
I'm not going to attempt to answer all of that question, but you're actually teeing me up really well, because there's going to be a follow-up survey that I'll go over at the end of our conversation together today that is touching on a lot of what you just described. Yep, we're on the same page. Does anyone else want to share anything or react to Divya's suggestion there?
I would just say ditto. It's an excellent point.
All right, we're going to move forward. Oops. There we go. So the staff debriefed the majority of the comments together and came up with a handful of actions we plan to take by the end of the year. One of the themes was that there's a perception that work group members and CAC members are more likely to receive funding. Anecdotally, speaking for myself, I would probably agree with that statement, but we don't have any statistics put together on that. And we also don't know whether that's a good thing or a bad thing. And so the staff is going to come together and discuss that perceived bias and address it openly with the work groups, and just not let the elephant sit in the room without anyone talking about it. It's been a conversation, a side conversation for, I think, several years, ever since we started giving away money. So that's one of the things that we definitely heard. Folks encouraged us to become more public facing and let people know who we are. And Donna always warns us not to try to draw attention to ourselves because it usually works, but we have a social media plan now. So if you're on Instagram or LinkedIn, you can follow us. We are starting to do some public outreach that way. We are building a plan to connect with some of the underserved voices in our community. The networking portion was one of the surprises for us. We did not realize that as a community convener, we were so instrumental in introducing people to each other, introducing partners who may eventually work together. And we heard several asks to lean into the networking aspect and create more community connections. And we thought that was really interesting about how people could partner more effectively and deduplicate services and just be more aware in general of what's going on in the community. It used to be a lot easier when we were all in the same room. Now that we're virtual, it's probably going to look a little different, but strength we didn't know we had.
So Kelsey, here's a suggestion. In our strategic planning in my agency, we are looking forward to a gradual reopening and recognizing that the social, so much of our success is within our teams. We have very much a team approach to how we do business. And the relationships within the teams have suffered because of all the social distancing. And that plays itself out in a whole lot of ways within the agency here. I think a parallel process a case can be made. There's a parallel process within the social networking, the networking systems that you're talking about, that some of that has suffered, the connections have suffered because of all the social distancing. And so thinking through how to rebuild those connections once we can be live, which maybe in just 6 months or something, maybe less, that that is a worthy thing to think through. Just a comment.
Thank you, that's encouraging. It ties directly into the next item that's on the list, which is tech needs. I don't know if you all have noticed, but we've had across the board in committees and work groups just buco attendance. Everybody's here, and to your detriment or not, sorry about the Zoom fatigue, but we heard two different sides of comments during the survey. Half of them were saying, it's so awesome that you're virtual because you used to always meet and bend, and I can attend new meetings now and participate and represent my area so much more easily. And then the other half of saying, can't wait till we're back in person. This whole Zoom thing is just not sustainable. So we will be considering that as we negotiate what returning to in-person looks like, if it's some kind of hybrid model, if it's staggered. We're not sure. We know there's value in both. We've really struggled before to have more participation from outside of Deschutes County, and we don't want to lose sight of that as we try to return to what I will refrain from calling business as normal. And the last part was about RIP work group comments. We did not explicitly ask for feedback on the RIP work groups, and about half maybe a little bit less of all the comments that were submitted were specifically about the RIP work groups. So we, as a staff, decided to debrief those separately because they were also interrelated. And so we heard them, and we will be carrying the feedback from those back to the work groups and negotiate that with them over the next couple of months. And this brings me to my questions for you. Since it's the first time we've done this, I am curious, you can answer either of these questions, whichever one speaks to you. What caused you to become curious and want more information? And what is valuable for you as a board member in seeing these survey results?
So Kelsey, if I could jump in. And this is kind of going back to the previous slide, and it might help with, it might link to this last question. That notion of, and perception is critical. Is there truly a bias for investments? And I heard you say you're going to look at what's there, but I wasn't clear if you were saying you literally were going to see in this particular work group, the investments went to these people, and if we say these people are connected and this group is not connected, what percent did? I wonder if that would be helpful information or not. Perceptions are reality and they're critical, but it might be nice to know what is also actually happening, and be able to compare that as well. So I'm curious about that. And then the other piece with that, and I hope I'm not perseverating on this one, is that I think you asked it, how important is that in terms of, is that an invitation to have more people become involved? Is that a message of, yeah, only the well-connected are going to get any of our money? I think all those, I see that as a staff question, but I think that ultimately becomes a board question as well, in terms of what it is we're trying to do. And if there's a perception of we have our favorites and they get the money, that's certainly not what we were, I don't think that's what any of us signed up for.
So I think we want to parse out carefully what's the meaning of that. You know, with 250 volunteers, that's a lot of organizations. And so so the question I think needs to be framed carefully is, do you have a wide distribution of organizations that are getting the money versus is there a select few? And because I think participating in the work groups, which are pretty easy access, you show up, you do the work, that increases the likelihood that the proposal would be in sync with what we're trying to do, so long as it's a wide distribution. So I think there's arguments to be made in a lot of ways. And so we can frame this in a way that is automatically negative that I'm not sure it is. So we want to think about this critically.
Yeah, I agree, Rick. We're in a small community, and so I don't want that to sound like an excuse, but I like the perspective of the distribution of it. Also, Paul, I love your perception is reality. I'm not sure if that works with my husband and the dirty dishes that are in the sink right now. But for this, I think it's absolutely relevant. The breaking it down in a single work group and asking who's getting funding and who's not. We could take it to that level. I defer to Donna's wisdom on whether or not that's valuable, or to the PM's wisdom, as they're the closest to the work groups themselves. I think the greater value is elsewhere, but that's just my own opinion. Other great questions. Thank you for those. Other thoughts and reactions so far? Yeah, Linda.
I appreciate this information, and I keep going back to Divya's question about where the health council And for what purpose are we building these community partnerships? And it's because one is you can take it right down to the microscopic level and then go back to the stellar level. It's whatever health problem has been identified through the Regional Health Improvement Plan has a strong social determinant of health undercurrent. And the health system per se has a primary purpose of addressing some aspect of that, but our community partners do the rest of it. And so in the absence of a wide range of partnerships, we're limited in our ability to really move heart disease or childhood immunizations or childhood resilience if we don't have a way with our partners to address those social determinants of health. And that leads right into the piece of is money going to insiders? And from my perspective, that's another reason to continue to expand our network. I'm aware, for example, I'm not on this task force, I'm on a different one, but we have on the upstream prevention work group, which I am a part of, there's a group that's working on reading readiness for K through 3. Mm-hmm. And being a member of Rotary, I know my Rotary Club and the regional Rotary clubs have a set of activities that they fund and do focus on the same thing. I happen to know a couple of faith-based organizations that have book bag programs, the same objective. They're not all talking to each other. So it could be more efficient and probably more effective if we widen the net and get as many people that we know of into the conversation of at least knowing each other and deciding how they can collaborate better. And it brings me right around to what continues to keep me in Central Oregon, although now that I'm retired, it's less so. But the first 15, 20 years I was here, when I moved here in 1998, Bend was 35,000. And it was unique in the connections that the movers and shakers had with each other and the ease of picking up the phone and calling and scheduling a coffee with total strangers. If you had a community problem to resolve, it was very easy to get in contact with the people who needed and had the money to do something, and you would just convert that right into a project. And it's been one of the things that I think is most at risk with the growth of this community is to lose that ethic. And I think the model that we're using with the networking in the regional health improvement groups, in particular the work groups, is that if we weren't doing it that way and creating those connections, I think it really is at serious risk of being lost. So I think the work groups are doing an important role of keeping those connections going. And the more people that know about funding that's available, the more people will apply.
So Brad puts in the chat, I do not think work group members should not, okay, I'm sorry, I read that wrong. I do think work group members should not receive any favoritism when it comes to funding. Many organizations just don't have the bandwidth capacity for work groups, committees, boards. It was pretty clear to me years ago when I started checking out COHC and its funding procedures that participating in the work group you hope to get funding from ups your chances of getting funding. Maybe that's changed, I'm not sure. Okay, and any other comments?
I will go into the part that Divya has so clearly teed me up for if we're ready to move on. We're almost done. The next survey that we release will come out either tomorrow or Monday, but by Monday at the latest, on how we are perceived and the reason that people continue to show up. And as I said, to put words to that, we will have a very data-driven beginning of the survey and then an opportunity for people to volunteer to give key informant interviews to discuss the value of the Health Council. The way I put it to the staff as we were talking about this internally was the reason that people sign up for Amazon Prime is free 2-day shipping. Why do people come to the Health Council? What's our free 2-day shipping? What's the thing that if we stopped doing it, people would leave? So that is the theme of this next survey that is coming out. I encourage all of you to take it. It is optionally anonymous. If you'd like to be interviewed, then we'll have you leave your name. Otherwise, you can leave your comments freely. And I will warn you, there is a quiz. And you will find out whether or not you know the facts of the Health Council. And to tie this in with the strategic plan presentation that we won't have time for today, but that Donna will give next month, the strategic direction in your plan is demonstrating effective governance, creating simple and concise multi-level external communications plan for board member and partner use is one of the first year accomplishments that we set out to do. And stating our value and defining why we're important and why we matter and who we are, and whether that's to all people or just to some people, that is a huge part. It's on the action plan for that, that red circled accomplishment there. And it is a supporting factor for the sections in blue, which we will discuss in depth at our meeting next month. And that's all I have.
Okay. Any other, thank you very much for that presentation. It was engaging, very good. Any other questions? We're delaying Donna Mills' report on the strategic plan for next month. Otherwise, we can give her a minute. So that seemed a little short for a strategic plan update. Any other comments? Okay, it was a good meeting. May I have a motion to adjourn?
Move to adjourn.
Okay, all in favor, say aye. We're done.
Aye.
Have a great day, everybody.
Thanks,
Goodbye.
everybody.